Here's how health insurance breaks down in the United States. There's about 320 million people in the country. About 28 million of them don't have insurance. That doesn't mean they don't get healthcare services. It doesn't mean they don't go to the doctor or don't need a hospital. It just means that they don't have health insurance to pay for it. That leaves about 292 million Americans who have health insurance. Now, that's broken down into two large groups. One large group is people who have private insurance, and that is, they get insurance through a company. Another is people who get public coverage through the government and government programs. When we consider the private insurance side, that's further broken down into two groups. The first and by far the largest group is about 180 million Americans who get their health insurance through employers. About 52 million Americans buy their private insurance themselves. They actually contract with an insurance company themselves to get health coverage. In addition to the private side I mentioned, there is also the public insurance side, which we will talk about next. Health insurance in the United States is not cheap. It actually costs a lot of money. Last year, the average premium for a family health insurance plan was $19,000. And the worker contributed out of pocket an average of $6,000 for that health insurance plan, or about 30%, with 70% being contributed through the employer. You can see that the health insurance system is very complex and very expensive. Next, we are going to talk about the public health insurance programs, Medicare, Medicaid, and other public programs to cover healthcare costs for different groups in America. Let's start with Medicare. Medicare was passed in 1965 and enrolled its first people in 1966. Originally, it was composed of two parts, Part A and Part B. Part A was to cover hospital care services, and it was modeled on Social Security. It was paid for through payroll taxes. Some of the money coming from the employer, some of the money coming from the worker. And it paid the hospital bill. Part B was to pay for physician services as well as some other services, including x-rays, lab tests, as well as some other specialized drugs and physical therapy. Part B is not paid through payroll tax. It's paid through premium that the individual Medicare beneficiary pays, about 25% of the cost, and 75% of the cost comes from general tax revenue. Then in 1997, Medicare added Part C, or what's called Medicare Advantage. It's a managed care kind of program. Private insurance companies advertise to elderly people, and if they want it, they sign up. The private insurance companies have to provide all the services covered in Part A and Part B, and they can cover additional services like drugs and other services. But they are responsible for all of the care of the elderly. In 2006, under President Bush, Part D, or the drug benefit for Medicare, was enacted. Again, this is a voluntary program the elderly can opt in. If they do, they have to pay a premium that covers about 25% of the cost. But the general tax revenue covers the other 75% of the cost. And about 30 million of the 50 million people in Medicare take Part D. In addition to all the government programs, there is Medigap, which is a private program to fill in the holes of Medicare. It's a way that the elderly can buy insurance to pay for deductibles, coinsurance, and other co-payment programs. When Medicare was started in 1966, there were about 19 million people. Over the years, it's grown tremendously, so that today there's about 52 million people enrolled. Most of them, the vast majority of them, are the elderly at 65, but some of them are non-elderly disabled. One large group of that are patients who have end-stage renal disease. Medicare pays for their dialysis and their kidney transplant. In addition to paying for hospital, doctor care, and drugs, there are some other add-on payments that Medicare gives so that the government can support what it considers worthy programs. Let's just highlight three of them. One of them is called Graduate Medical Education, or GME. This is payments to hospitals to train interns and residents. And the federal government spends about $10 billion paying hospitals to train them. Disproportionate share hospitals, or more commonly known as DSH payments, are payments from the federal government to hospitals who care for the uninsured to compensate them for the free care they give to uninsured people. That comes to about $11 billion a year. And then Critical Access Hospitals is another federal program supporting small hospitals, those with fewer than 25 beds in rural areas that provide emergency services to rural residents. That comes to about $8.5 billion a year. That's Medicare, the program for people who are 65 years and older. Next, we are going to talk about Medicaid, how poor people get their health coverage through the government. Medicaid passed at the same time as Medicare and was targeted to the poor people. Today, about half of the people who get Medicaid are children. Another quarter are pregnant women and parents of the children. And a quarter are elderly and disabled. Poor elderly people in Medicaid pays for those provisions that Medicare doesn't cover. It turns out that while a quarter of the people are elderly and disabled, they actually use almost 2/3 of all the Medicaid dollars. The Medicaid dollars don't flow to children and adults, but to the disabled and elderly. It's important to contrast Medicare and Medicaid. While they were passed at the same time, they are very different programs. In Medicare, once you turn 65, you get the program. You don't have to file papers, there are no complex eligibility requirements. In addition, it's exclusively a federal program. The same rules apply throughout the United States for everyone on the program. On the other hand, Medicaid is a very different arrangement. It's conditional. You have to prove you're eligible. Not everyone who is poor is eligible. Second, it's a joint federal-state program in two senses. It's funded jointly between the federal government and the state. Federal government pays on average 57% of the cost. It pays more for poor states and less to richer states, and states pick up the rest. It's also a joint federal and state administrative program. The federal government sets minimum eligibility criteria for what needs to be covered, and then the states make the final eligibility determinations and what's covered and how it's administered. In addition to Medicare and Medicaid, the federal government has a program called CHIP, Children's Health Insurance Program. CHIP was passed in 1997. It was meant to fill in a gap, provide coverage for children who were ineligible for Medicaid, cover those children who were uninsured. Again, like Medicaid, states set the eligibility criteria. Like Medicaid, it's a joint federal-state finance program. Today, about 9 million children get CHIP, and it costs about $16 billion. In addition to Medicaid and Medicare, there are a number of other large public programs. For example, Department of Veterans Affairs covers veterans. There are about 150 veteran hospitals in the country. There are about 800 veteran outpatient facilities. This is a program which the federal government both owns the hospitals and employs the doctors. It is true socialized medicine, and it costs about $53 billion per year. The Defense Department has TRICARE, which provides services to about 9 million active military personnel, retirees, and their dependents. And there is the Indian Health Service, which provides services to the Native American populations. And there are a few other programs around.